Hello, this is Dr. Morris. I'm doing the lecture on the respiratory system. This is part 2. I'll first start by talking about external respiration and internal respiration. The general term respiration refers to two integrated processes, the external respiration and the internal respiration. The precise definition of these terms vary from reference to reference. External respiration includes all the processes involved in the exchange of oxygen and carbon dioxide between the body's interstitial fluids and the external environment. The goal of external respiration and the primary function of the respiratory system is to meet the respiratory demands of cells. Internal respiration is the absorption of oxygen and the release of carbon dioxide by those cells. Now, this lecture will discuss biochemical pathways responsible for oxygen consumption and the generation of carbon dioxide by mitochondria, pathways known collectively as cellular respiration. Now, there are three integrated steps involved in external respiration. They include pulmonary ventilation, gas diffusion, and transport of oxygen and carbon dioxide. For pulmonary ventilation, or breathing, which involves physical movement of air into and out of the lungs. Gas diffusion occurs across the respiratory membrane between the alveolar air spaces and the alveolar capillaries and across capillary walls between blood and other tissues. The transport of oxygen and carbon dioxide between alveolar capillaries and capillary beds and other tissues. Slide 6 gives you an illustration from your textbook demonstrating pulmonary ventilation and its relationship with the lungs. You can also see oxygen transport and CO2 transport on this illustration, as well as gas diffusion, which involves the exchange of oxygen into and out of the cell tissues. Abnormalities in external respiration include abnormalities affecting any one of the steps involved in external respiration. This will ultimately affect the gas concentrations of interstitial fluids and thereby cellular activities as well. If the oxygen content declines, the affected tissue will become starved for oxygen. Hypoxia, or low tissue oxygen levels, places severe limits on the metabolic activities of the affected area. An example, the effects of coronary ischemia results from chronic hypoxia affecting cardiac muscle cells. If the supply of oxygen is cut off completely, the condition of anoxia will result. Anoxia kills cells very quickly. Much of the damage caused by strokes and heart attacks is a result of localized anoxia. Pulmonary ventilation is the physical movement of air into and out of the respiratory tract. The primary function of pulmonary ventilation is to maintain adequate alveolar ventilation, movement of air into and out of the alveoli. Alveolar ventilation prevents the buildup of carbon dioxide in the alveoli and ensures a continuous supply of oxygen that keeps pace with absorption by the bloodstream. To understand this mechanical process, we need to look at some of the basic physical principles governing the movement of air. One of the most basic is that of our bodies and everything around us are compressed by weight of the Earth's atmosphere. Although we are seldom reminded of this fact, this atmospheric pressure has several important physiologic effects. For example, air movement into and out of the respiratory tract as the air pressure in the lungs cycles between and below atmospheric pressure and above atmospheric pressure. The primary differences between liquids and gases reflects the interaction among individual molecules. Although molecules in a liquid are in constant motion, they are held closely together by weak interactions such as hydrogen bonding between adjacent water molecules. Because the electrons of adjacent atoms tend to repel one another, liquids tend to resist compression. If you squeeze a balloon filled with water, it will distort into different shapes, but the volume of the new shape will be the same as that of the original shape. This is Boyle's law. In a gas, such as air, the molecules bounce around in independent entities. At normal atmospheric pressure, gas molecules are much farther apart than the molecules in a liquid. so the density of air is relatively low. The forces acting between gas molecules are minimal. The molecules are too far apart for weak interactions to occur, so an applied pressure can push them closer together. Now, consider a container of air at atmospheric pressure. The pressure exerted by the enclosed gas results from collisions of gas molecules with the walls of the container. The greater the number of collisions, the higher the pressure. You can change the gas pressure within a sealed container by changing the volume of the container, thereby giving the gas molecules more or less room in which to bounce around. If you decrease the volume of the container, the collisions will occur more frequently over a given period, elevating the pressure of the gas. Gas molecules in a sealed container bounce off the walls and off of one another, traveling the distance indicated in a given period of time. If a volume decreases, each molecule will travel the same distance in that same period, but will strike the walls more frequently. The pressure exerted by the gas increases. If the volume of the container increases, each molecule will strike the wall less often, lowering the pressure of the container. The following illustration demonstrates if you increase the volume, fewer collisions will occur per unit of time, because it will take longer for the gas molecules to travel from one wall to the other. As a result, the gas pressure inside the container will decline. This illustration is from your textbook, again showing a decreased volume of pressure and an increased volume as the pressure falls. Smaller container, more collisions. Larger container, less collisions. An inverse relationship thus exists between the pressure, P, and the volume, V, of a gas in a closed container. Gas pressure is inversely proportional to the volume. That is, if you decrease the volume of a gas, its pressure will rise. If you increase the volume of the gas, its pressure will fall. This is Boyle's law. The relationship between pressure and volume is reciprocal. If you double the external pressure on the flexible container, its volume will drop by half. If you reduce the external pressure by half, the volume of the container will double. This relationship, first recognized by Robert Boyle in the 1600s and referred to as Boyle's law. Airflow from an area of higher pressure to an area of lower pressure, thus, or this tendency for directed airflow plus the pressure-volume relationship of Boyle's law provides the basis of pulmonary ventilation. A single respiratory cycle consists of inspiration or inhalation and expiration or exhalation. Inhalation and exhalation involve changes in the volume of the lungs. These changes create pressure gradients that move air into and out of the respiratory tract. Now, there's an important relationship with the pleural cavity, or the cavity that surrounds the tissue of the lung. Each lung lies within a pleural cavity. The parietal and visceral pleura are separated by only a thin film of pleural fluid. The two membranes can slide across one another, but they are held together by this thin fluid film. A comparable fluid bond, or a pressure volume, exists between the parietal fluid and the visceral pleura, covering the lungs. As a result, the surface of each lung sticks to the inner surface of the chest and the superior surface of the diaphragm. Movements of chest wall or diaphragm thus directly affect the volume of the lungs, the basic principle shown in the following slide. Again, this demonstrates the relationship between the pleural cavity and the lungs, and also the relationship between the diaphragm, which is the muscle which is responsible for at least 80% of the respiration. As you can see, when the diaphragm contracts, it increases the volume of the lungs. The pressure outside and inside are equal, so no air movement occurs. Pressure inside falls, so airflow in the lungs will also change as the volume increases. When the volume decreases, the pressure inside rises, so air will flow out. This is a previous illustration as shown earlier, again demonstrating the mechanism of pulmonary ventilation, O2 and CO2 transport, and gas diffusion to the cellular level. Now, mechanisms of ventilation refer specifically now to inhalation. As the ribs are elevated or the diaphragm is depressed, the volume of the thoracic cavity increases. Inhalation, elevation of the rib cage, and contraction of the diaphragm increases the size of the thoracic cavity. Pressure decreases and air flows into the lungs. Exhalation, when the rib cage returns to its original position, the volume of the thoracic cavity decreases. Pressure rises and air moves out of the lungs. The volume of the thoracic cavity changes when the diaphragm changes position or the rib cage moves. The diaphragm forms the floor of the thoracic cavity. The relaxed diaphragm has the shape of a dome that projects superiorly into the thoracic cavity. When the diaphragm contracts, it tenses and moves inferiorly. This movement increases the volume of the thoracic cavity and exerts pressure on the contents of the abdominal pelvic cavity. When the diaphragm relaxes, it returns to its original position and the volume of the thoracic cavity decreases. Due to the nature of the articulations between the ribs and the vertebrae, superior movement of the rib cage increases the depth and the width of the thoracic cavity. Inferior movement of the rib cage reverses the process and reduces the volume of the thoracic cavity. At the start of a breath, pressure inside and outside the thoracic cavity are identical, and no air movement into or out of the lungs occurs. When the thoracic cavity enlarges the pleural cavities, the lungs expand to fill the additional space. This increase in volume lowers the pressure inside the lungs. Air now enters the respiratory passageways because the pressure inside the lung is lower than the atmospheric pressure. Air continues to enter the lungs until their volume stops increasing. The internal pressure is the same as the outside. When the thoracic cavity decreases in volume, pressures rise inside the lungs, forcing air out of the respiratory tract. The compliance of lungs is an indication of their expandability. The lower the compliance, the greater the force required to fill the empty lungs. There are factors affecting compliance: the connective tissue structure of the lungs, the level of surfactant production, and the mobility of the thoracic cage. For the connective tissue structure of the lungs, the loss of supporting tissue results from alveolar damage, as in emphysema or chronic obstructive pulmonary disease, increases compliance. For the level of surfactant production, on exhalation, the collapse of the alveoli as a result of inadequate surfactant, as in respiratory distress syndrome, primarily seen in newborns, reduces the lungs' compliance. The mobility of the thoracic cage, or in the case of arthritis or other skeletal disorders, affects the articulation of the ribs or the spinal column, which also reduces compliance. At rest, muscular activity involved in the pulmonary ventilation accounts for 3 to 5% of the resting energy demand. If compliance is reduced, that figure climbs dramatically, and individuals may become exhausted simply by trying to continue to breathe. To understand the mechanism of respiration, the principles of gas exchange, we must know the pressures recorded inside and outside the respiratory tract. We can report pressure readings in several ways. In this text, we shall use millimeters of mercury as we do in blood pressure. Atmospheric pressure is also measured in atmospheres. 1 atmosphere of pressure is equivalent to 760 millimeters of mercury. Now, the concept of intrapulmonary pressure. The direction of airflow is determined by the relationship between atmospheric pressure and intrapulmonary pressure. Intrapulmonary pressure, or intra-alveolar pressure, is pressure measured inside the respiratory tract at the level of the alveoli. When you are relaxed and breathing quietly, the pressure differences between the atmospheric and intrapulmonary pressure is relatively small. On inhalation, your lungs expand and the intrapulmonary pressure drops to about 759 millimeters of mercury. Because the intrapulmonary pressure is 1 millimeter below atmospheric pressure, it is generally reported as on exhalation. Your lungs recoil and the intrapulmonary pressure rises to 761 millimeters of mercury. This illustration from your textbook illustrates the phases of inhalation and exhalation. The graph on the next slide demonstrates or follows changes in the intrapulmonary and intrapleural pressures during a single respiratory cycle and relate to changes in tidal volume. The size and the pressure gradient increases when you breathe heavily. When a trained athlete breathes at a maximum capacity, the pressure differentials can reach during inhalation if the individual is straining or the glottis is closed. This is one of the reasons you are told to exhale while you're lifting weights. Exhaling keeps your intrapulmonary pressure and your peritoneal pressure from climbing so high that your alveoli will rupture or a hernia could occur. There is a maneuver referred to as the Valsalva maneuver, exhaling less forceful against a closed glottis. A procedure known as Valsalva maneuver causes a reflective change in blood pressure and cardiac output due to compression of the aorta and the vena cava. When internal pressures rise, the vena cava collapses and the venous return decreases. The resulting fall in cardiac output and blood pressure stimulates the aortic and the carotid baroreceptors, causing a reflective increase in the heart rate and peripheral vasoconstriction. Baroreceptors are basically receptors that are located inside the aortic and carotid arteries, again that cause a reflective increase in heart rate and peripheral vasoconstriction. I would recommend you look up aortic and carotid baroreceptors to further understand this concept. When the glottis opens, the pressure returns to normal and venous return and cardiac output will rise. Because vasoconstriction has occurred, blood pressure rises sharply, inhibiting the baroreceptors. As a result, cardiac output, heart rate, and blood pressure quickly return to normal levels. The Valsalva maneuver is thus a simple way to check cardiovascular response to changes in arterial pressure and venous return. Intrapleural pressure is the pressure measured in the space between the parietal and visceral pleural. Intrapleural pressure averages about, but can reach during a powerful exhalation. This pressure is below atmospheric pressure due to the relationship between the lungs and the body wall. The lungs are highly elastic. In fact, they would collapse to about 5% of their normal resting volume if the elastic fibers could recoil completely. The elastic fibers cannot recoil significantly, however, because they are not strong enough to overcome the fluid bonds between the parietal and the visceral pleural. The elastic fibers continuously oppose that fluid bond and pulls the lungs away from the chest wall and the diaphragm, lowering the intrapleural pressure slightly. Because the elastic fibers remain stretched even after a full exhalation, intrapleural pressure remains below atmospheric pressure throughout normal cycles of inhalation and exhalation. Cyclical changes in the intrapleural pressure are responsible for the respiratory pump. This is the mechanism that assists the venous return to the heart. A respiratory cycle is a single cycle of inhalation and exhalation. The tidal volume is the amount of air you move into and out of your lungs during a single respiratory cycle. At the start of a respiratory cycle, the intrapulmonary and the atmospheric pressures are equal and no air is moving. Inhalation begins with the fall of intrapleural pressure that accompanies the expansion of the thoracic cavity. Intrapulmonary pressure drops to a certain level and then begins to rise as air flows into the lungs. When exhalation begins, intrapleural and intrapulmonary pressures rise rapidly, forcing air out of the lungs. At the end of exhalation, air movement again ceases when the pressure differences between intrapulmonary and atmospheric pressures has been eliminated. The amount of air moved into the lungs during inhalation is equal to the amount moved out of the lungs during exhalation. That amount is referred to as the tidal volume. Now, a specific injury that can occur in the lung is referred to as a pneumothorax. A pneumothorax is an injury to the chest wall that penetrates the parietal pleura, or a rupture of the alveoli that breaks through the visceral pleura can allow air into the pleural cavity. This is referred to as a pneumothorax. This pneumothorax breaks the fluid bonds between the pleura and allows the elastic fibers to recoil, resulting in a collapsed lung or atelectasis. The treatment for collapsed lung involves the removal of as much of the air as possible from an affected pleural cavity before opening is sealed. This treatment lowers the intrapleural pressure and reinflates the lung. I will now discuss the mechanics of breathing. You may move air into and out of the respiratory system by changing the volume of the lungs. Those changes alter the pressure relationship, producing air movement. The changes in the volumes of the lungs occur through the contraction of skeletal muscles, specifically those that insert on the rib cage and the diaphragm, which separate the thoracic and abdominal pelvic cavities. The skeletal muscles involved in the respiratory movement were covered in AMP1. Of those, the most important is the diaphragm, as I alluded to earlier, and the external intercostal muscles. These muscles are active during normal breathing at rest. The accessory respiratory muscles become active when the depth and frequency of respiration must be increased markedly. These muscles include internal intercostal, sternocleidomastoid muscles, serratus anterior muscles, pectoralis minor muscles, scalene, transversus thoracic muscles, transversus abdominis muscles, external and internal oblique muscles, and the rectus abdominal muscles. You should be familiar with these accessory respiratory muscles and the primary respiratory muscles. The following illustration demonstrates movement of the ribs and the diaphragm that increases the volume of the thoracic cavity. Diaphragmatic movement. Also, illustration demonstrates anterior view at rest with no air movement, showing the primary and accessory respiratory muscles. This view is taken from your textbook. The following illustration demonstrates a lateral view during inhalation, showing the muscles that elevate the ribs, a lateral view during exhalation, showing the muscles that depress the ribs. The abdominal muscles that assist in exhalation are represented by a single muscle, the rectus abdominis muscle. The diaphragm. Inhalation is an active process involving the contraction of one or more of these muscles. The contraction of the diaphragm increases the volume of the thoracic cavity by tensing and flattening its floor, and this increase draws air into the lungs. Diaphragmatic contraction is responsible for roughly 75% of the air movement in normal breathing at rest. The external intercostal muscles assist in inhalation by elevating the ribs. This action contributes to 25% of the volume of air in the lungs. Accessory muscles, including the sternocleidomastoid, the serratus anterior, the pectoralis minor, the scalene muscles, can assist the external intercostal muscles in elevating the ribs. These muscles increase the speed and the amount of rib movement. Exhalation is either passive or active depending on the level of respiratory activity. During exhalation, the internal intercostal and the transversus thoracic muscles depress the ribs and reduce the width and the depth of the thoracic cavity. The abdominal muscles, including the external and internal oblique, transversus abdominis, and the rectus abdominis muscles, can assist the internal and the intercostal muscles, or the internal intercostal muscles, and exhalation by compressing the abdomen and forcing the diaphragm upward. Artificial respiration is a technique used to provide air to individuals whose respiratory muscles no longer are functioning. In mouth-to-mouth resuscitation, a rescuer provides ventilation by exhaling into the mouth or the mouth and nose of the victim. After each breath, contact is broken to admit passive exhalation by the victim. Air provided in this way contains adequate oxygen to meet the needs of the victim. If victim's cardiovascular system is non-functional as well, a technique called cardiopulmonary resuscitation, also known as CPR, is required to maintain adequate blood flow and tissue oxygenation. The respiratory muscles are used in various combinations depending on the volume of air that must be moved into and out of the system. Respiratory movements are usually classified as quiet breathing or forced breathing by a pattern of muscle activity in the course of a single respiratory cycle. In quiet breathing, or eupnea, inhalation involves muscular contractions, but exhalation is a passive process. Inhalation usually involves the contraction of both the diaphragm and the external and internal intercostal muscles. In costal breathing, or shallow breathing, the thoracic volume changes because the rib cage alters its shape. Inhalation occurs when contractions of the external intercostal muscle elevate the ribs and enlarge the thoracic cavity. Exhalation occurs passively when these muscles relax. Diaphragmatic breathing. During diaphragmatic breathing or deep breathing, contraction of the diaphragm provides the necessary change in the thoracic volume. Air is drawn into the lungs as the diaphragm contracts and is exhaled passively when the diaphragm relaxes. Elastic rebound. During quiet breathing, expansion of the lungs stretches their elastic fibers. In addition, elevation of the rib cage stretches opposing skeletal muscles and elastic fibers in connective tissue of the body wall. When the muscles of inhalation relax, these elastic components recoil, returning the diaphragm, the rib cage, or both to their original position. This phenomenon is referred to as elastic recoil or elastic recoil. Diaphragmatic breathing typically occurs at minimal levels of activity. As increased volumes of air are required, inspiratory movements become larger and contribution of rib movement increases. Even when you are at rest, costal breathing can predominate when abdominal pressures, fluids, or masses restrict diaphragmatic movement. For example, a pregnant woman increasingly relies on costal breathing as the uterus enlarges and pushes the abdominal viscera against the diaphragm. The concept of forced breathing, or hyperpnea, involves active inspiratory and expiratory movements. Forced breathing calls for accessory muscles to assist in inhalation, and exhalation involves contraction of the internal intercostal muscles. At absolute maximum levels of forced breathing, the abdominal muscles are used in exhalation. Their contraction compresses the abdominal contents, pushing them up against the diaphragm and further reducing the volume of the thoracic cavity. Your respiratory system is extremely adaptable. You can be breathing slowly and quietly one moment and rapidly and deeply the next. The respiratory system adapts to meet the oxygen demand of the body by varying the number of breaths per minute and the amount of air movement per breath. When you are exercising at peak levels, the amount of air moving into and out of the respiratory tract can be 50 times the amount moved at rest. Your respiratory rate is the number of breaths you take each minute. The normal respiratory rate of a resting adult ranges from 12 to 18 breaths each minute, roughly 1 for every 4 heartbeats. Children breathe more rapidly at rates of about 18 to 20 breaths per minute. We can calculate the amount of air moved each minute, symbolized by multiplying the respiratory rate by the tidal volume. This value is called the respiratory minute volume. The tidal volume at rest varies from individual to individual, but averages around 500 milliliters or 500 cc's per breath. The respiratory minute volume at rest, 12 breaths per minute, is approximately 6 liters per minute. Now, alveolar ventilation. The respiratory minute volume measures pulmonary ventilation and provides an indication of how much air is moving into and out of the respiratory tract. Only some of the inhaled air reaches the alveolar exchange surfaces. A typical inhalation pulls about 500 cc's of air into your respiratory system. The first 350 cc's inhaled travel along a conducting passageway and enters the alveolar spaces. The last 150 milliliters or cc's of inhaled air never gets further than the conducting passageway, and it does not participate in gas exchange with blood. A volume of air in the conducting passages is known as the anatomical dead space. Alveolar ventilation symbolized is the amount of air reaching the alveoli each minute. The alveolar ventilation is less than the respiratory minute volume because some of the air never reaches the alveoli but remains in the dead space of the lungs. We can calculate alveolar ventilation by subtracting the dead space from the tidal volume. At rest, alveolar ventilation rates are approximately 4.2 liters per minute. The gas arriving in the alveoli is slightly different from that of the surrounding atmosphere because the inhaled air always mixes with the used air in the conducting passageway, the anatomical dead space, on its way to the exchange surfaces. The air in the alveoli thus contains less oxygen and more carbon dioxide than does the atmospheric air. The respiratory minute volume can be increased by increasing either the tidal volume or the respiratory rate. Under the maximum stimulation, the tidal volume can increase to roughly 4.8 liters. At peak respiratory rates of 40 to 50 breaths per minute and the maximum cycle of the inhalation and exhalation, the respiratory minute volume can approach 200 liters or about 55 gallons per minute. In functional terms, the alveolar ventilation rate is more important than the respiratory minute volume because it determines the rate of delivery of oxygen to the alveoli. The respiratory rate and the tidal volume together determine the alveolar ventilation rate. For a given respiratory rate, increasing the tidal volume will increase the alveolar ventilation rate. For a given tidal volume, increasing the respiratory rate will increase the alveolar ventilation rate. Only a small proportion of air in the lungs is exchanged during a single quiet respiratory cycle. The tidal volume can be increased by inhaling more vigorously or exhaling more completely. We can divide the total volume of the lungs into a series of volumes and capacities that can be experimentally determined. The values obtained are useful in diagnosing problems with pulmonary ventilation. Many respiratory volumes and capacities differ by gender because adult females on average have smaller bodies and thus smaller lung volumes than do males. This illustration, taken from your text, demonstrates the various lung volumes or lung capacities that are seen. Some definitions of pulmonary volumes. The resting tidal volume is the amount of air you move into and out of your lungs during a single respiratory cycle under resting conditions. The resting tidal volume averages 500 cc's or 500 milliliters in both male and females. The expiratory reserve volume, or ERV, is the amount of air that you can voluntarily expel after you have completed a normal, quiet respiratory cycle. As an example, if with maximum use of the accessory muscles, you can expel an additional 1,000 cc's or 1,000 milliliters of air, your expiratory reserve volume is 1,000 milliliters. The residual volume is the amount of air that remains in your lungs even after the maximum exhalation, typically about 1,200 milliliters or 1,200 cc's in males and about 1100 milliliters or 1100 cc's in females. The minimal volume, a component of the residual volume, is the amount of air that would remain in your lungs if they were allowed to collapse. The minimum volume ranges between 30 and 120 milliliters, but unlike other volumes, it cannot be measured in a healthy person. The minimal volume and the residual volume are very different because the fluid bonds between the lungs and the chest wall prevent the recoil of the elastic fibers. Some air remains in the lungs even at minimal volume because the surfactant coating the alveolar surfaces prevent their collapse. The inspiratory reserve volume, or the IRV, is the amount of air that you can take in over and above the tidal volume. Inspiratory reserve volumes differ significantly by gender because on average the lungs of males are larger than those of females. The inspiratory reserve volume of males averages 3,300 cc's or 3,300 milliliters compared to 1,900 milliliters or 1,900 cc's in females. The inspiratory capacity is the amount of air that you can draw into the lungs after you have completed a quiet respiratory cycle. The inspiratory capacity is the sum of the tidal volume and the inspiratory reserve volume. Functional residual capacity, a term that you should be familiar with, is the amount of air remaining in your lungs after you have completed a quiet respiratory cycle. The functional residual capacity is the sum of the expiratory reserve volume and the residual volume. The vital capacity, another term you should become familiar with, is the maximum amount of air that you can move into or out of the lungs in a single respiratory cycle. The vital capacity is the sum of the expiratory reserve and the tidal volume and the inspiratory reserve, and averages around 4,800 milliliters or 4,800 cc's in males and approximately 3,400 to 34 cc's in females. The total lung capacity, another term you should become familiar with, is the total volume in your lungs. The sum of the vital capacity and the residual volume. The total lung capacity averages around 6,000 milliliters in males and 4,500 milliliters in females. Pulmonary function tests monitor several aspects of respiratory function by measuring rates and volumes